Hey, good morning and welcome to UroNurse, your number one place to go for urology healthcare education. If you're watching us live, welcome to the show. Hey, you YouTube subscribers, over that way. Nope, that way. You YouTube subscribers, we're so close to 2,000 subscriptions, I can taste it. If this is your first time checking out the show, be sure to go to uronurse.com to learn more about the show. Best place to go to watch all of our past episodes. And if you want to listen to us in the car, just go to UroNurse Plus area on our UroNurse website, and you'll find all different ways. Any of your favorite podcasting apps, you can listen in the car. So today we got a really interesting talk. We're going to be talking about the trial of void. Now, when I first saw this on the latest SUNA meeting, trial of void, I'm thinking, that's a talk? But Diane Newman made it a talk. So she's joining us as one of our experts today. Let's bring in our experts today. So let's bring them all in here. Experts, welcome to the show. Hey, how's everybody doing?
Good.
I'm going to just let everybody do a quick introduction, then we'll get going to the show here. Let me just bring in our slides. So I'm going to go ahead and bring Lori in here and go ahead and introduce yourself.
Good morning, everyone. My name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology since 1998. Currently work for Northwestern Medicine in Geneva and Winfield.
All right, thanks. And Diane, you probably don't need an introduction, but why don't you go ahead and introduce yourself?
Hi, I'm Diane Newman. I'm a nurse practitioner. Practice at the University of Pennsylvania. I've been in urology since 1986, so a little bit older than Lori. And basically, I do a lot of research in this area, but I've done a lot of voiding trials, Vic.
Yep. Yeah. And you're humble when you say you do a lot of research in this area.
Well, I've been around a long time. So if you're around a long time, you've done a lot of different stuff in urology.
Yeah.
Like you, Vic.
I've never been a big one for research, but I'm starting to change my tune a little bit because I'm starting to do a little bit of my own kind of mini research projects on things because it's just interesting to see kind of what we test, I like to say is test dogma. So it's kind of interesting. So for those of you who don't know who I am, maybe this is your first time joining us. Welcome. My name is Vic Sinise. I'm the host and producer of the show. Started this over 2 years ago, and it's been a blast. It's just so much fun to have great experts to talk about different subjects. And there's just seems to be a never ending list of things we can talk about. So we're going to go ahead and start today. I'm going to keep the experts on the screen for this show because they're going to be hopefully interrupting me with all sorts of stuff. And I invite you, the audience, to go ahead and do the same thing through the comment box. Go ahead and put any questions you might have during the show. This is an open discussion. So let's go ahead and bring it in. So why are voiding trials even necessary? Good question, right? So the definition is pretty simple. It's basically to assess a patient's ability to void after you take out their catheter. We want to do it for several reasons, and we'll talk about some of those. So again, it evaluates bladder function, prevents urinary retention, and reduces complications. Complications are not a minor thing either. When we're talking about complications, I call being stuck in a crazy emergency room that's crowded and nobody knows what they're doing half the time, especially when it comes to putting catheters in. And you've got a bladder that's full and getting fuller. That's a complication. So you want to prevent those. I always say if you can keep a person out of the emergency room, that's huge. So a little definition, urinary retention is the inability to empty the bladder completely. Common causes post-op, especially some of the surgeries are more prone to this. I always find, and I don't know, I can bring it up to the experts, but I see a lot of patients post hernia surgery that have retention. Has that been anybody else's, Diane or Lori?
Absolutely, 100%.
Yeah. Yeah, no, and you're right. What you're bringing up, though, is that a lot of what we get for voiding trials in urology offices is, like you say, post hernia, post other surgeries than GU, right?
Yeah.
I mean, hernia, I've seen actually back surgery, several that had retention, brain surgery. So they come from, I hate to say it, all different types of specialties, but it tends to be mostly post-op, right? Do you think that, Lori? It's, I think, mostly post-op patients.
I agree.
Yeah, I know we see a lot of them. And one of the things, we talked up, just as you mentioned, neurological conditions like back surgery, brain surgeries. We know prostate enlargement can cause it. And then sometimes medications. I see a lot of that. Patients will come into the office and you ask them about their medications, and they were taking antihistamine because it's allergy season. Well, you know what
Yeah,
it's like
right.
the negatives or the opposite of taking Flomax. It tightens them.
And constipation,
Oh, that's a good one.
which is
Yeah.
huge.
So it is true. There's just a lot of things that can cause urinary retention, and we see it all the time. Patients come in with that catheter. The first thing they ask you is, "Get this out of me."
Yeah.
Yeah, exactly right.
All right. Now, if you didn't know this, there are two types of voiding trials. The active voiding trial, which is performed with assistance such as bladder filling. We used to call that the pull and pull. Wow, I can't talk today. Fill and pull system. There we go. And the passive one, where you just take a catheter out and let the bladder fill up naturally. Now, one of the things that we've always been good here at Euronurse is kind of addressing dogma. And I think that in this particular case, we probably all have had ideas of what's best. Do we do a fill and pull? Do we just take the catheter out and have them come back later? Let's get some of the experts' thoughts on that. What do you think, experts? Diane, what's your favorite way to do it?
Well, I think that the natural is in some ways the best, but in urology office, over time, we realized that they were in the office, we have them come in, they'd be in the office all day, and it got to be such a backlog of patients that we really got into the active, and actually I've gotten really into that. One thing I'll tell you is that I really started this way back in the 90s when I had a home care practice, and I needed to actually determine, taking out these catheters, how could I do that within a short period of time? And that's really when I started using the active way back then. And I used to use, an IV bag, which of course now with the hurricanes, we don't have a lot of them, but IV bag with tubing into the Foley catheter. So the active goes back a long time with me, but I think what I'm trying to say is, out of necessity, what do you do? In home care, that makes sense. I can't stay around all day in the home or in the office. I don't know what you do, Lori, but in your practice.
Lori?
So currently, I've been in urology so long that I've been to a few different practices. One actually never did active voiding trials. They always just had the patient come in. They had to come in early in the morning. We take their catheter out. They come back in the afternoon if they need to, or they come back in the afternoon for just a PVR to check to see how well they're emptying, just to be safe for the rest of the evening. Currently, what we're doing, we don't do voiding trials on everyone. I guess it depends on what kind of surgery or what their issue was. But yes, we do the active voiding trial on most patients.
Now, I kind of spit out there the dogma thing. So I think that, a lot of us pick based on some prejudice that we might have. Now, for me, I do a lot of urodynamics. And one of the things I noticed doing urodynamics is, as you're filling a bladder, if it's filling up kind of quickly, they can get a contraction just from the filling.
Yeah.
So my dogma was, that's probably a bad idea to do these fill and pulls, because we're filling the bladder artificially. That might cause it to contract. Maybe they empty out because of that and not because they're able to empty out. So I'm more favored the passive.
It's those patients that come in and their first thing is like, I always have the urge to go to the bathroom with the catheter. And those are the ones that I know, as soon as I start filling them up with water, they're going to contract, and it's just going to be not even worth it. Just pull it and have them do it naturally.
Yeah.
But Vic, whenever you look at the literature, though, but back to that, I think it's important that most of the literature deals with voiding trials in hospitals post-operatively, and they talk about, and mostly what nurses are doing in acute care is really the passive. They don't really, they're not doing that as far as filling the bladder up and all that. They probably don't have time, but also I think that expertise. So something to remember, we talk about we're all in urology practices, but a lot of the voiding trials are done either after an outpatient procedure or, prior to discharge, right, to get that patient out of the hospital without a Foley.
Yeah. And that's a perfect segue into my next slide, evidence-based research. So, of course, that's where I was listening to Diane's talk, and she started throwing some evidence out there because, of course, there's some studies out there. But I did my own study, too. I asked our humble audience to fill out a survey. And I said, how do you perform a voiding trial? And interestingly enough, the majority are doing the fill and pull route where they do a active. So that was kind of interesting. Now, of course, these are small numbers and you can, argue that whether it's significant or not, but I think it's interesting to hear what my audience had to say. And then the one that was surprising to me is the small percentage that have the patient remove the catheter at home and return to the office in the afternoon. I think that's an overlooked thing because for us to do a passive fill, we would have the patient come in early in the morning, take out their catheter, go home, drink fluids, and then come back later that day for post-void residual. Well, that's 2 trips into the office. That's my time, their time. So I think that's something we're overlooking as a possibility. Then I asked them, if you fill the bladder in your office, what amount do you put in? And I thought this was kind of interesting. It seems like most focused around the 200 cc. No, actually the 25%?
Yeah, the 300. Yeah.
Yeah. Most were figuring around the 300. But they're all over the place. You can see that wheel's got lots of color in it. So, you wonder how much the research would say to that. So let's look at some research. This was done by, I think that's the British Journal of Urology, BJUI.
Mm-hmm.
And this particular one put in some normal saline, 300 to 500 cc's infusion. One of the interesting things is they warmed their solution. I think that's probably not a bad idea because I think cold solutions can sometimes make the bladder more reactive. But their conclusions were the infusion method is safe and expeditious, the British, making it ideal for the outpatient setting. This randomized study shows that the infusion method enables a rapid determination of outcome of trial avoid with a greater chance of success in shortened discharge times. And I think you're right, Diane. I think this might have been done in a hospital setting.
Mm-hmm.
Another one that I found was a systematic review and meta-analysis. So these were looking at the charts of patients who had trial avoids done. And their conclusion was the bladder infusion technique of trial avoid may be associated with a significantly increased likelihood of successful trial avoid and reduced time to discharge compared to standard trial avoid practices. So another one that is supported by the research. And then again, just kind of going back to sort of supported what I found in my little short research study. Put it out to my experts. So what do you think as far as, Diane, evidence out there? You're the one who's always looking at this stuff.
Yeah, you brought up a point before about in the home. And actually, there's a very recent study, and I forget the main author, but who actually post-gynecological surgery had the patient do it at home. And as I said, the SUNA meeting, I was approached a couple years ago, I think actually during COVID, by our Penn Home Health Care Agency, that gynecology had approached them about doing voiding trials at home. And so I think that in that area of specialty, they may be trying to get the patient to do it at home because they have this sometimes same-day surgery. They want to get them out. And the point about these voiding trials that's happening in acute care is, what is the aim? Get them out of the hospital, right? As soon as possible. So, catheters, and they don't want the catheters to stay in. So this is so part of catheter removal. But you're seeing more research, but again, mostly around either urology, post, say, a BPH, Urolift or whatever, those types of surgery, or gynecology surgeries where you're seeing some of the research.
Yeah. I think the hardest part about people taking their own catheters at home, they don't want to. They're afraid to. They don't know what to expect. And I think that's a big challenge for the people, for having them try to do that at home.
I think especially for men, right, Laurie? I mean, first of all, I don't know about you, but I've had a personal situation with trying to take out a family member's catheter, a male family member. He would never have done it. And I think that, they're going to want to have it done by a professional. And you got to worry about that because one of the things I think is making sure that balloon is really all that fluid is out when you remove the catheter. Yeah. So, and Vic, you taught me something just a little bit ago about the fact about instilling the fluid if you do an active. That's a really good point, is that if we don't do it slow, and
Yeah.
if it's cold, it can trigger a bladder spasms, right? Which may just be because of the circumstances, the environment, and not be really that physiological thing going on. I didn't think of that. Thanks. That's a good tip.
Yeah. And actually, the fill and pull that I would do, because again, my dogma, my prejudice with urodynamics. So when a doctor insisted, no, I want you to do that, I go, fine. Then what I did is I got a Toomey syringe, took out the plunger, put it into the catheter, and I would do a pour. So
Oh,
it could be a slow infusion. It infuses. And what's interesting is if they ever get a bladder spasm, you'll just watch the level rise up the Toomey. So it's
Yeah, you
pretty
know what?
neat.
I did that too. We used to do that where we pull the plunger out and pull. I find better for me, or in general, I keep the plunger in, and so I go ahead and fill them that way. If they have a spasm, you'll see it come up, but you can control it. So, when you see that come up, I stop. I wait
Mhm.
for it to kind of subside and try to slowly push a little bit more in at a time. If you have the plunger out, it's kind of like sometimes it actually whoosh, it goes way, it can go pretty quick. So
but okay, so there's three of us who have a lot of good urologic experience, and we've just described three different ways that we're doing it, depending on where we are. And one of the thing about the research, Vic, that I really is terrible is there's nothing from nursing in this literature. There's actually, I
Yeah.
think, I shouldn't say there's one publication was in one of the nursing journals, and I forget which one, where he just said they actually described that, but I think it may be a British journal. But we need more of this type of urology procedures in print, right? Because you're bringing up a good point, Lori, because when I heard Vic say that, I thought, well, that's a really neat idea. But you are right, too. What can happen is that it can, with a spasm, it might just come back up. So we're all talking about different ways that we have found that work.
Yeah. And still, I don't know that we have a definite, what's the proper volume to put in, all
Right.
this questions that need to be answered. For those that like to do research, this is a wide open category. And like I said, when I first saw the subject matter, what was going to be talked about at the SUNA meeting, I was like, trial avoid, come on. Then I saw Diane was talking about it. I said, well, okay, I'm going to go because I'm a Diane fan. So I went, and I'm like, this is special. This is something we really need to be looking at. I said, I'm going home and making an episode. So that's why I invited Diane on. So it was great. All right. So let's talk a little bit about the procedure. So if you're just doing obviously a passive, you can just take the catheter out, send them home. Or as I like to think about, give them the option of taking it out before they come in, with the patient removing it. I've got some ideas I'll talk about for that. Uh, Bladder fill. We just talked a little bit about some options for how we should fill the bladder. Do you heat the water? Do you not heat the water? Do you do it by gravity? Do you plunge it? So voiding attempt is then done, and then we assess how well they empty. Equipment that you need for this is a catheterization kit, a bladder scanner, sterile water, urinal measuring type device, and documentation tools. So I did ask my illustrious audience who removes the Foley catheters in your office, because I just was interested. And this is what I found out. Probably no big surprise. We talked about this at SUNA quite a bit. Medical assistants are more commonly found in the office now than RNs. So they're doing the bulk of it, but doctors are doing it, NPs, PAs. So we have a variety of people taking them out. The procedure for removing a catheter, you should prepare the patient. I always think it's a good idea not just to go yanking at a tube, because as Diana mentioned, people are scared of this. So explain the procedure, reduce their anxiety, comfortable positions. I always have patients laying on their back on the table. I think it's the best way. Ensure privacy and maintain dignity throughout the procedure. Those of us that have been in this for a long time, sometimes I think we forget that. You're just so used to, okay, drop your drawers, let's get rid of this, catheter. So keep in mind, they're still a human being. Find the inflation port on the catheter. Pretty simple for most of us. Attach a syringe to the balloon and slowly deflate the fluid by pulling back on the plunger. As Diane made a point, make sure that you're getting all of it out. And that's really kind of a question mark too, because did you ever get it all out? Because you don't know what's in there. They came in, like you said, from surgery sometimes. So you don't know how much they put in. A 10 cc balloon. Now, this is my own research. I want my experts to tell me, do you know how much a 10 cc balloon will hold before it explodes?
I don't know that.
I'm going to guess. So I know you can put more in. So I know it's probably at least 30. At least 30 to 50.
All right, Diane, with all your experience, what's your best guess?
Well, I mean, that's a great, I've never done that, Vic. Now, I never even thought of that. I mean, I've always the 10 cc. Well, I would think 20 cc's because we do have the 30 cc.
Would you believe 90?
Wow.
What?
90 cc's. And I tried it over several balloons. I mean, it wasn't just one. 90
Really?
cc's was the average that they would hold before they burst. They'll burst, but it takes a lot. So, I mean, you can have a 10 cc catheter easily with 30 cc's in it or more. One of the issues that you sometimes have if you overinflate these is the balloon will actually come up and obstruct the ports. So that's why when
well,
it's a 10
and the
cc
other thing
balloon,
too is, and if you underinflate, they don't really become symmetrical, and that's the thing. And I mean, you're young, Lori, but Vic probably remembers this. Remember, we always would say you only put 5 cc's in a 10 cc balloon, and they've always been 10 cc's. So we've gotten away from that. That's something that old wives' tales, right? That we now do realize is you want to put that full 10 cc in there so it's symmetrical. But that's an interesting thing. You're bringing up what is your views on, do you deflate the balloon before you start the voiding trial if you're doing an active one, or do you leave the balloon inflated?
I like it inflated.
Inflated, yeah.
You leave it inflated.
If they have a spasm, they can shoot that catheter. If that balloon's not in there, it literally will shoot the catheter out.
I just was wondering about that. I tend to deflate it also, but I've had other nurses tell me, "Oh no, then what happens is it falls out before I'm done." So I know.
Yeah, I keep it inflated while I'm filling for that reason, because if they do have a spasm, it does slide out.
Yeah, I've always deflated it, but anyway, it's interesting again the differences between what we do.
Yeah,
it goes back to what you're saying. It's old wives' tales or just something that we've always done. Yeah, it's already done that way.
All right, good. All right. Now, one of the things that I don't think we always think about when we're doing these is location. How far is the patient from a bathroom? Because if you don't have, now we're lucky enough in our office that we have bathrooms in every one of our suites so that patients can get to the bathroom quickly, but they're Jack and Jill bathrooms. So we have two exam rooms and a bathroom between them. So you have to lock one door, leave the other one open. So always make sure that the one that's getting the trial avoid has the open door. But sometimes they do want to go to the bathroom relatively fast.
Mm-hmm.
So I asked our group, how do you measure post-void residual? Because I'm old enough before the ultrasound even existed that we were putting catheters in everybody to do a trial, a post-void residual, not a trial avoid, but just any post-void residual. Thank God everybody's 100% using bladder scans. It makes my heart feel better.
Mm-hmm.
So what's a successful voiding trial? So a void should be probably greater than 200 cc's. So you have to get at least 200 cc's in their bladder, or more than that, and they should get out at least that. And a post-void residual of under 150 cc's. Signs of an incomplete voiding is voided urine is less than 200 cc's and post-void residuals 150 cc's. So I did ask my audience what they thought a normal post-void residual was, and they kind of zoned right into what the research was showing me, the 150 cc's. We have any thoughts on that from the experts?
I truly believe that it all depends on the person. There's no set number. It's just like filling them. If they went to the ER and they had 2 liters drained and they're coming in for a voiding trial, chances are you're going to fill them up with more than 200 cc's. Because that problem's probably been going on for quite some time. That's my opinion. When they void, again, it depends on how much. I mean, you could look at their history sometimes and see, are they ever going to be able to, I mean, if they're post voids for 300 in the past, you're not going to stick a catheter in if they have 250, 300 in their bladder after a voiding trial. So it really does depend on history.
Yeah, Lori, that's one thing that Lori's bringing up a really good point. It's history. So and it worries me whenever, your data showed that even though it was a small sample, we're saying AMAs are doing it. what was the history, that voiding history of that individual prior? You know, if
Yep.
it was a man who said, oh, you know, I don't have a good stream, or a woman who says I have to strain, then it really does, you have to think about that when you're looking at what are they voided and what's their post-void residual. The other thing, though, I think that what's important is how much did you put in? So if you only got, I don't know, 150 in and they have 150, so they said, oh, I went a little bit, then, you know, that's too much. I mean, so that's why the one answer, 1/3, I think you have to look at the entire procedure. How much did I put in? I don't know. How much do they drink? Some people even, before you go to the bathroom, I want to scan you to see how much is in your bladder so that you know that, hey, there's, okay, 400 cc's, they voided, I don't know, they voided maybe 275, and you may have a higher post-void, but hey, they voided a good amount. Let's see you go home and see what happens. So it really does take a little bit of critical thinking. I mean, I don't know what you two think, but that's what worries me as far as, and I know in these practices, we're also guilty of this. We go to the person who can just run in there and do it. And it tends not to be a nurse practitioner or PA. And I know in ours, we've been doing more LPNs do it, but you do need some critical thinking there.
Yeah, it also depends on, you know, how the patient's feeling too. You know, if they have, you know, if they peed, but they're leaving 300 behind and they don't feel, they have no urge to go to the bathroom, like I will be like, okay, let's just wait and see. Or you can get somebody with 200 still or under 200 feeling like, yeah, no, I still have to go, but I can't. You know, it's different.
Yeah.
Right.
And we know bladders can get overstretched, so they're not as compliant. So maybe somebody's carrying around 200, 300 cc's, not having infections, still is voiding enough to keep their bladder and kidney health going. So as Diane said, critical thinking is huge here. You need to have the experience and the know-how to evaluate this. And, you know, you need to read the history too.
I'm going to throw in a comment from Janelle Finn. I think that's how to pronounce her name. That she said we need to void 2/3 of the volume, and I've heard that before, where people will say, like, you know, it's okay if it's half the volume we put in. And again, I don't think there's really a number on it. I think that 2/3 is a good. It's a good number. We usually do half, depending, you know.
Yeah.
But I think, Janelle, that's a really good point. When you read this literature, a lot of them do state that, yes, it should be at least 2/3 of the volume put in. But again, even reading this literature, I don't see a lot of, but what was the pre-assessment done on these individuals? This is especially true, you guys, with non-urologic patients. You know, everybody assumes someone who's coming back from back surgery, brain surgery, hernia, has normal bladder function. And you and I know that we know that's not true. And you know, and I think that's where sometimes it's missed. Oh, well, they're just coming from the surgery. I'll just do the voiding trial and that's all. But you really need to know what is the history, what were they doing prior. And we know 1/3 of women, especially with aging, have incontinence. Were they incontinent before? So you're right. What you're saying is there's a lot of factors that do influence voiding trials that I think are not thought about by the person doing them.
Absolutely. This is something that Diane brought up in her talk. So if somebody doesn't pass or doesn't actually void up to that, you know, 2/3, double voiding, do we do that? Is that something that we do? Pretty simple procedure. Just have the patient sit around, go back into the bathroom. I think one of the other things is, and I mentioned having a bathroom close by, you know, if you tell the patient, you know, give a male patient a urinal and you're in the room and say, go ahead, try to empty your bladder. That's not really the best way to do a trial of void. You know, they need to be able to have some privacy. Some people like to have running water to kind of mask the fact that they're urinating. There's things that they can do like bladder percussion, that bladder tapping, stimulation therapy, things like that to help to empty their bladder better. So these are things that we should always keep in mind when we're doing a trial of void. Get lost. Now, when we're successful and the patient doesn't have a big residual and they get to go home without their catheter, we're having a party. It's great. And you can tell patients are so happy to get out of there without that.
Right.
But what happens when that doesn't work, when it fails? That's not a real happy patient. So what are our options at that point? And this is where I'm going to kind of bring it out to my experts, what you offer, and my thoughts. I'm going to bring you guys up here. So my thoughts is this is the perfect patient to address the thought of doing intermittent catheterization, because I don't want to put a catheter back in the patient, and I know they're going to get infected. We got plenty of research to show that in about a week's time, everybody's bladder becomes infected with a catheter. So I'd like to get them catheter free. They've actually had a taste of freedom. You've given them 6 hours of running around without a catheter. So it's a good time to approach that. If there's, I don't think there's any better time to try to talk to a patient about doing intermittent cath. So what are your feelings, Diane?
Well, I agree with you 100%. But I mean, first of all, they're traumatized by having the catheter in. They've got to come in with it. And then they're like, what do you mean I have to cath myself? This is really where judgment's so important. It really depends on what's going on. If they do not void at all, I don't think we have any other choice. And that's, I think, when the question comes up, Vic, do we put the Foley back in or we do intermittent cath? Yep. I always want to do intermittent cath in that case. But again, depending on what's going on in the situation in your practice, I see a lot, let's put the Foley back in, come back in a couple of days, is what I hear. So and again, no research on this as far as what do you do. There's some research, with women that take the catheter out post hysterectomy and that, sending them home on intermittent cath just in case. But I don't really know what the right answer is there. I don't know, Lori, what your practice is, but sometimes there's so many other factors that influence what that next step is.
Yep.
Yeah.
Lori,
it really depends. I know. Let's take, for example, a patient who is in the ER for urinary retention. They come back in the office. They started, let's say, tamsulosin. It's a male, and they come back a couple days later, and we do a voiding trial, and they don't pass. We don't necessarily jump to CIC or intermittent catheterization at that point. A lot of times, we'll give it another week with a catheter, and then they come in, if they failed for a cystoscopy, to take a look inside. Maybe at that time, that's when if everything looks okay, and maybe it's enlarged prostate or whatever, we will talk about CIC at that point, but we don't necessarily jump to it right away. But it depends. It really depends on the person and what they had done, or if they had surgery, like a BPH surgery or something like that. So there's different scenarios to that for sure.
Yeah. So again, we get back to that critical thinking. It's where expertise comes in. You kind of get to know and a feel for the patient. I had a patient once who had, an atonic bladder, really was a very active social guy. And I said, why don't you just do intermittent catheterization? He says, there's no big deal about wearing that bag. He was just happier with the bag. He says, I don't have to ever worry about where I can go and having to
getting up at night.
Getting up at night. Yeah. I mean, so sometimes, we once again, we use our own prejudice to say, I wouldn't want to be running around with a catheter. You'd be better off this way. But patients should have a say. I think that conversation should include the patient. My thought is after they've been free of a catheter is a good time to at least approach the subject of talking about intermittent cath. Right. I think that to me, it's a much better lifestyle for patients.
Sure.
All righty, let's get back to our research here. So we did talk about that. Some patients are going to have a catheter put back in. So I was just kind of curious on this one. Who puts the catheter back in your office? And right now, the majority were nurses doing it. But of course, medical assistants are crawling up into that realm. I was surprised how many doctors actually do it, and NPs and PAs. So we do have a pretty good variety. I think we're going to see those numbers a year from now shift quite a bit too. Then I asked, who teaches intermittent self-catheterization in your office? So that was the bulk of it was being done by RNs, medical assistants, NPs. Very few MDs are doing it. I think that I've never seen too many docs that want to take the time that it takes to spend to teach intermittent catheterization. It's always done to their, other assistants. So not too big of a surprise. Who decides the type and size of the intermittent catheter you give to your patient? So this one was interesting. It was different than I thought. NPs are really strong in being the ones, and I think a lot of offices now have this collaborative practice with the urologist, their NP, and then their MAs or RNs. So the NPs are the ones they're going to for that, which makes me happy. So we're getting that critical thinking, and doctors too. Asking the doctor what to use. I'm going to bring you guys back on
Vic,
screen.
about that. Yeah, Vic, I'm really surprised on a lot of your answers. The MD's doing it.
Yeah.
I did not see that in my practice.
No.
I think we have pretty experienced nurses, so our nurses can determine what kind of catheter and so forth, because doctors actually trust us to know what's best for the patient, because we're the ones dealing with, how they're feeling and how easy things go and what kind to put in, what's going to be easiest for the patients to hold on to. There's a lot of different factors in that.
It's interesting about that because like being in academic medicine and in urology, even our residents, someone needs to be taught intermittent cath. They come out of the room, grab somebody, and a lot of times it may be the LPN or of course an RN, or hopefully an RN at least. Oh, go teach them how to do it. And I was recently, about a couple of months ago, at a dinner they had for my ex Chief Alan Ween. And a lot of our old residents, because we really have a lot of residents that come through Penn, came there. And I can't tell you how many came up to me and said, Diane, I wish I had spent more time with you learning about pelvic floor bed catheterization, because now in practice, that's what I'm doing. And it was really an interesting thing that, a lot of what nurses and advanced practice providers have taken on is because the training has been more in the surgical realm. But when you go out into basic urology practice, they need to know the whole gamut. And I think it's interesting when, that you came up with some of these, that the MD is doing it. Because again, in my practice, I don't know, Lori, maybe with yours, I really have not seen them do it. And quite frankly, and I don't know, I know we're recording this, I wouldn't want some of them to teach it because I'm not so sure they have the knowledge base of the variety of intermittent catheters, right? What's the best thing? What's the coding that makes sense for this specific patient? All that kind of thing. I don't know if they have that knowledge.
Yeah. That's really important for those of us that teach intermittent catheterization. As you said, you have to know what catheter is going to be best for what patient, because not every patient is going to be perfect for a hydrophilic catheter. If you don't have really good grip strength, sometimes it's better to have a catheter that you lubricate so you can keep part of it, dry so you can actually handle it. So there's all sorts of different techniques. Prostates, you might want to use a coude. Sometimes elderly patients that are a little bit confused, a coude is terrible because they can put it in upside down more than they do right side up. So there's all sorts of things that get involved in that. The one thing that my biggest pet peeve is a lot of companies come in with this bag o catheters. I don't know if you guys get that in your office, but I get it. It's got, they're a company that sells everything, so they don't really care what you use. But it's got 5 different brands, different sizes, and they just give it to the patient. And, and a lot of our folks will just say, here's what you need. Go home and see which one works best, and we'll order it. That's crazy to me.
Mm-hmm. I'm with you 100%.
I completely agree with you. I am not a fan of those bags. I pick what I think might work best for the patient. We work with it if it works. Now, if they're comfortable with how they're doing it, once they learn how to do it and they're comfortable doing it, yes, I will introduce other catheters. Sure. But I'm not at the first visit giving them a bag of 12,000 different catheters, because personally, I don't even know. I'd have to really look at them to make sure I know how that catheter is working, because there's so many different kinds.
I'm with you.
It's a recipe for failure, I think so.
Yeah.
All right. So the next thing I said is, do you give patients written instructions on self-catheterization? This one made me really happy because I think that for me, and my entire career has been spent mostly in patient education. I'm a big proponent of giving them something to take home, because I know when I've been to a patient for something, the last thing I do is pay attention. Your mind is just wandering all over the place. Give them something to take home so they've got something to refer back to. And if you're not going to do that, then I do have a suggestion. send them over to europatient.com, my podcast that I put together every Saturday for patients, because that's where they can get the education if you're not going to be doing it. I've got some videos already on how to catheterize, kind of explaining those mysterious leg bags and how they work, and even how to do your own catheter removal. And I'll tell you, interestingly enough, because we do a lot of these minimally invasive things like resumes and urolifts, we send patients home with a catheter, have them remove it themselves, and give them the option of it. We don't make them do it. We tell them, hey, you can do this. And like you said, sometimes they're afraid. Well, I've also got a little QR code on my instruction sheet that takes them right to this video that they can watch on how to take out their own catheter. When they watch the procedure, I would say 99% of them will decide to do it on their own instead of coming in. This particular video, by the way, I looked this morning, like 15,000 views already. So, and Europatient's been out for less than a year. So one's only been out probably maybe 4 or 5 months. So the other thing is handouts. Like I said, I have a lot of handouts that I like to give patients, general information, something to take home and read. So I was actually at the SUNA meeting and somebody came up to me and said, I really love your Europatient because we don't really have handouts for our patients. So we just send them to your site to get their handouts. So I think it's a good service for patients. Anyway, my little ad for Europatient. What type of catheters do you use? I wanted to kind of find out, is there a certain percentage of something that people like better than others? The ready to use pre-lubricated kind of was the leader of the pack, followed by hydrophilic. I know Diane knows a lot about this subject, so I'm going to bring her up here. Diane, what are your thoughts on which is the best type of catheter?
Well, I guess I'm kind of partial to the hydrophilic. I think that I got away from, external lubrication because I had a lot of patients that don't do it correctly. And the pre-lubricated, I think, are good too. But a lot of the pre-lubricated also have a hydrophilic catheter, actually whenever the fluid hits that surface, it becomes, hydrophilic. So yeah. I think that those two are very similar. So I tend to gravitate towards there. And the data shows there's less trauma. Now, the thing about, though, after a voiding trial, though, is that hopefully that individual isn't going to have to cath long-term. And we may want to just consider a simple catheter with lubricate it and that's it, and then reevaluate their voiding function, right? Because that's something we should talk about is when do you bring them back? How are you doing? Can you stop doing the catheterization? Because I think where we want to, recommend these catheters that are less complicated, less urethral trauma in that is really when they do long-term catheterization. So that's something I think that we're not differentiating. One size doesn't fit all is what I'm saying. And you really have to look at the situation.
Laura, your thoughts? What type of catheter do you typically?
I generally go with the hydrophilic as well. I just think it slides in easier. It's less work for the patient to have to put lubricant on the catheter and all that good stuff.
The only problem about hydrophilic, and I had this with some older patients, is it's so slippery they drop it.
Yep.
Yeah, they do have the grippers now, which and people, time and time again, I have to remind them, especially when they're first starting, you have to pull that guide back. They try to keep putting it in, and then you'll see the sheath start to pull. You got to pull it back, and you got to hold on hard because that's the other thing is they'll be going like this, and that sheath's just going back and forth, and you got to put some pressure on it.
Yep. Right. So I was a big one that was a holdout for using hydrophilic. It took a sales rep who I knew for years. He was with a different company who had switched over to a hydrophilic catheter company. And he said, just try it for crying out loud and then let me know. And I said, well, okay, I got to give you that nod since I know you. And so I did try it on the next patient. And I'm like, there's something to it. It was a lot easier for the patient to put in. My prejudice on him was I don't like the stiffness. Now, I know a lot of the newer ones aren't so stiff, but the early on hydrophilics were really stiff catheters, and trying to get around, men are not straight, women straighter. Men got that S curve they got to get around. And, the stiff catheter can sometimes be more traumatic to put in. But I have to say they do definitely have a good spot for them to be used. So, all right.
But Vic, you bring up a really good point, though. But I go back and forth with the stiffness and the flexibility, because what I've seen with men, well, maybe because I've a lot of older men trying to get the catheter in and it flipping around, and then in some ways they're contaminating everything. So you're right. It's really difficult to find that not too stiff, but not too soft, flexible catheter, right? And
It's the Goldilocks phenomena.
yeah, I know.
It's just right.
Yeah, it's a really good point, though.
Yeah, it is. And I think that's really where for the patients, getting the right expert is huge, because it's going to make a difference. Your results will vary. All right, we're almost done here. So the last thing I asked was, is there a brand preference that people have? Now, this is a messy slide because I allowed people just to put it whatever they wanted, so I did break it out. So it seems like a lot of patients are using Coloplast. Some don't prefer any difference. Whatever the patient feels comfortable with. Bard, depends. Cure, Convatec, GC Glide. Never heard of it before.
That's the general cath by Convatec.
Oh, okay. So lots of variations, and there's a ton of them out there, and probably a ton that are still going to be coming out. But that's the end of my discussion. So we'll start taking some questions, and just keep in mind that we need to fight against just doing things dogmatically. We probably need to be getting more research involved and trying to really answer some of these questions. But there is no substitute for experience. So, all right, Lori, can you bring some questions up from our audience?
Sure. I have more comments than I do questions. Early on, we were talking about the common people that we see in the office going into retention, post-surgical patients, things like that. Amy Wang brought up definitely the neurogenic bladder. We see that a ton. And those, unfortunately, are probably the people that are definitely going to be doing the CIC for long term. Janelle, Janelle Finn, she said, we base our input of sterile water based on max capacity identified on UDS. And that's a good point. And yes, if I have information like that, that'd be great. Of course, we're not going to be doing urodynamics on
most of the time you wouldn't have that.
Yeah, at the max capacity.
But that says something, and Vic, because I will tell you, I'm not an expert in urodynamics. When do you go, okay, so you take the catheter out, you find out that, okay, they're not completely empty. You're really worried about this because of whatever reason. Maybe you send them home with a Foley back in, depending on the volume, or maybe you teach them intermittent cath. When would you do urodynamics in that patient?
So for us, we're doing urodynamics after they failed trial avoid. And our big concern is it because of a hypotonic bladder or obstruction? So you're trying to get that decision made. And really, urodynamics is the only way that can really give you good data on bladder function. You're looking for that high pressure, low flow, not low flow, low pressure. You want to know that you got a good, strong bladder to squeeze. And you will get some capacities. If a patient has no sensation and you filled their bladder up with 600 cc's, chances are they probably have a hypotonic bladder. Right. So
and the interesting thing about that, I know that we used to do a lot of urodynamics, prior to BPH surgeries. A lot of our providers do urodynamics after. So they find out they have an obstruction, based on cysto or whatever. Yeah. They do the surgery anyway. Now, if they're still having problems afterwards, patients are always told that this could be a problem after surgery. We're going to relieve any obstruction that's there. But if they can't pee afterwards, they continue to have problems. At that point, that's when they do the urodynamic.
Oh, wow. Okay.
Yeah, well,
something to consider because you're right. But maybe that, some of these patients may have had urodynamics in the past too. That's also something we're back to the assessment of the history, what's going on, what's their previous, because they may have been part of the practice, and they just had some kind of GU procedure.
Yeah. There was one that came in early when I was looking at my emails, so I don't want to miss this one. I have seen situations when patients who pass the voiding trial, fill, pull, or spontaneous, but I still end up in the ER and retention the next day. Boy, I've seen plenty of those. Is there any way to prevent this? And how soon should I ask them to return for a bladder scan? Which was something Diane was starting to allude to, like, when do you follow up on these patients that we send out without, they pass their trial avoid? So Diane, what are your thoughts?
Well, in that case, it sounds like the patient successfully passed a trial void. So if you feel that they really did empty, I think the first thing is, and I'm glad to see all your patient teaching tools. I'm really into giving them information on watching how you void, what happens with your flow, so that they can pick up if possibly they're not emptying, so they don't end up in the ER. But really, if they void successfully, we don't, especially again, if they're not part of our urology practice, we don't have them come back.
Yeah.
So, I mean, how many end up with that scenario? I don't know. It does happen, but I don't know. I mean, it's get back to assessment. If they void successfully, if they voided maybe partially, I would have them back within a couple days. But I've had cases where we now do not schedule voiding trials on Fridays, you guys. Number one, because the staff doesn't want them around all the time, but also because we don't want a problem over the weekend. So that's also something, because of exactly maybe that scenario.
Or late in the day, so they end up in emergency room at night. You always have to think of staffing issues too. We prefer
sometimes in rare cases, if you get that patient who's a lot less fearful of catheters and so forth, and it is kind of one of those things where you're like, you may or may not. It's like one of those, okay, they peed just about half, but they feel okay, and we will give them a catheter on hand sometimes and just teach them in emergency, just to keep them out of the emergency room. Just to say, hey, if you really want to keep out of the emergency room, here's some catheters just in case, and then just follow up with us in the morning.
Great idea.
I have some more comments here. All right, because I don't want to miss any. So Janelle said, our gynae office, patients have urodynamics before surgery.
Okay.
And then Nyasha, sorry if I'm saying your name wrong, are voiding diaries helpful for those patients that are brave enough to want to pull their own catheter at home?
I think yes, definitely. And also I give them a voiding cath diary I have. So I actually have them also measure their outputs. I give them a hat and say, as part of their catheter removal. And then what I do is I have them measure, what their voided volume was, what the catheter volumes were, and then what their voided volumes were, and that type of thing to see. Because a lot of times, I don't know what you're seeing, but because of our backlog in patients, we do a lot of My Pen Health, right? So they give us information online, and that helps me a lot. I say, just put it in a message to me so I can see what you're doing. I'm using that quite a bit in all my patients, especially those that this type of thing. I want to know how what's going on. Don't call me. Send me a message in the portal. I find the portal the best thing that's happened to my practice, right? Because I hate. It's terrible that we don't want to talking to patients, but it's so difficult. I think, but I can do that on the weekends or whatever, and have that dialogue with them. Hey, what's going on? So I say to them, listen, and some of them will even scan their records and upload them into the portal so I can see it. By the way, diaries are wonderful for the audience. If you, with anything with urologic care, especially with low urinary tract dysfunction, and those you're trying to teach intermittent cath and that, cath records, voiding diaries, I just think they're just so helpful. I find in Philadelphia, patients just don't want to do it. And I know in some areas of the country, they're just very meticulous about it. But if you can do that, I really recommend those.
Yeah. I think it's probably one of the most overlooked tools that really gives so much information.
Exactly.
Not only just, you could see if somebody's after a trial of void, are they going like every hour? Is it, 20, 30 cc's? That gives you a pretty good idea whether they're retaining or not. What are they taking in, specifically are they taking bladder irritant type things? I drink, 10 cups of coffee a day, I'm drinking, 2 liters of beer a day, all these things that could affect your voiding. And they're so easy to miss. And all it takes is a voiding diary, and you can avoid some medications and things like that they typically get put on. So,
you're right. I don't know why urology hasn't adopted, because I always use the analogy of food diaries, right? Weight Watchers, you track what you eat. They have been shown to be an intervention. And I just think that a lot of times we don't really recommend that. But I do think too, and that's another topic for you, Vic. How to do avoiding diarrhea and how you read it, because I don't think that's taught to nurses in urology, and I just think it's neglected. And these records that really patient-centered records that could really help.
Yeah, great. All right, Lori, any other noise?
There was a comment from Rajesh Pai, spinal cord patients after accident 6 to 8 weeks. I'm not quite sure if he's talking about
probably after the spinal cord injury, that they wait 6 to 8 weeks because there's a spinal shock syndrome that happens right after spinal cord injury.
Yeah, so we don't deal with a lot of spinal cord injury where we're at.
Yeah, I think Raj works in the spinal cord center or something, because I think I've had some questions like that before. All right, I'm going to
bring up the neurogenic patient. I do think that's where urodynamics are needed. So that's something that the audience should know, that, again, back assessment. If you have someone who has some kind of neurologic, and we're not just talking about spinal cord, Parkinson's, stroke, even diabetics who may have a neuropathic bladder, right? MS, those individuals, that's a whole ever different presentation, Vic, as far as what do we do with those individuals we take out the catheter, because those are more complex patients.
Yeah, definitely. Yeah. All right, I got a little plug for next week's show.
Recent advances in prostate cancer screening have addressed the limitations of prostate-specific antigen testing, which has a lack of specificity and a risk of overdiagnosis and overtreatment. New biomarker tests offer greater diagnostic accuracy by targeting specific biomarkers and potentially reducing unnecessary biopsies. This 1.50 CNE Contact Hours educational activity aims to update healthcare professionals on advances in prostate cancer screening. The medical crossfire format facilitates discussion in the context of evidence-based presentations, highlighting the current challenges and opportunities in the field and providing practical advice for implementing best practices. Join us next week as Dr. Jason Haffron, Dr. Aaron Berger, and Dr. Arpit Shah battle it out.
All right, so join us next week for that. Next week's show is going to be longer than our usual show. It's going to be almost an hour and a half long. It does come with an hour and a half worth of credit that you can put in for. Dr. Arpit Shah and Dr. Aaron Berger are both physicians, advanced prostate cancer physicians in my practice. So it's kind of neat for me to get to watch them battle it out over this whole PSA controversy and when to screen and how to screen. So be sure to join us next week for that. Diane, it's been a pleasure having you on the show today. I know you'll be presenting in about a month, I think, for another episode for us. Lori, always great to have you on the show. So, and
thanks a lot for asking me. I appreciate it.
Yeah, this was fun. I've done a couple of these now where we just get some basic information from the audience and then kind of make a show around it and let the experts kind of, share some of their expertise. And I think it's been a lot of fun for me, it's fun to kind of discuss with folks about what they're doing in their own practices and then maybe make a difference in how they think about it for the future. So we'll see everybody next week on your